Welcome back to another episode of Curbside Consults, where we break down the practice-changing research from the New England Journal of Medicine. I'm your host, Dr. Angela Chen, one of this year's NEJM editorial fellows. Now, many of you would have by now heard about all these new classes of medications used to treat type 2 diabetes, and particularly the excitement around their cardiovascular benefits. So in today's episode, we'll be taking a deeper dive into the primary studies and answer some practical questions as well. Cardiovascular disease is a leading cause of mortality and morbidity in patients with diabetes. In 2017 alone, the cost of cardiovascular complications related to diabetes was $37.3 billion, and that was only in the United States. So it makes sense that the medications used to treat type 2 diabetes should also be evaluated for their potential cardiovascular benefits. What some of our listeners may not know is that this wasn't always the case. It was not always compulsory to evaluate for the cardiovascular outcomes in diabetes medication trials. Traditionally, we've relied on measures of glycemic efficacy such as HbA1c. The push to assess cardiovascular outcomes was started by the FDA in 2008 and occurred in response to controversies related to rosiglitazone, a thiazolidinedione. Studies including a meta-analysis published in the journal showed a signal of increased myocardial infarction risk in patients who had been randomized to receive rosiglitazone. So since that time and since those concerns, cardiovascular outcomes have been evaluated in all medications used to treat type 2 diabetes. In today's podcast, we will take a deeper dive into the literature to try to understand what are these new type 2 diabetes drug classes, to give a brief overview of their individual mechanisms of actions, and also to understand what the data from the randomized controlled trials have shown in terms of cardiovascular outcomes, and to provide a practical approach for things such as how to include these drugs in day-to-day patient management and what to do in hospital if you're looking after a patient using these medications. So joining in discussion today is Dr. Marie McDonnell. She is an endocrinologist and chief of diabetes and the director of the diabetes program at the Brigham and Women's Hospital. Dr. McDonnell is also a lecturer in medicine at Harvard Medical School, and we're very pleased to have her here today. Welcome to the show, Marie.
Thank you, Angela. Nice to be here.
So I'm just going to crack on and start. There are two drug classes that have been demonstrated to show some cardiovascular benefit: the sodium glucose cotransporter 2 inhibitors, the SGLT2s, and the glucagon-like peptide 1 agonists, GLP-1 agonists. Marie, can you tell us a little bit more about each class of medication?
Sure. So the SGLT2 inhibitors, we'll start there. Nicely, the name of this receptor inhibitor tells us what it does. So it helps in the kidney and the renal tubules to transport glucose and sodium together. The idea, I think, evolutionarily behind this receptor is to allow the body to hold on to glucose appropriately in sodium, but also to let it go. And it's important, we've learned, in maintaining normal glucose for the kidney to be able to excrete glucose. So we call that glycosuria. And when I was in medical school, that was something that you should avoid.
Yeah, of course.
And it was, in fact, and it still is, an important sign and symptom of diabetes, because hyperglycemia does allow the SGLT2 transporter to transport more glucose into the urine for excretion. Now, of course, with the development of drugs that we've seen, since the 1990s, we've seen a massive development, and now we have 10 classes of drugs. The glucagon-like peptide 1 agonists are agents that take advantage of normal physiology, similar to the SGLT2s, except they're agonists instead of inhibitors. And to activate the receptors of this peptide that we all produce normally, it's secreted mainly by the cells in the gut. And the peptide works on the pancreas and the liver and probably other cells, including the brain.
Oh, there you go.
So it helps to increase insulin secretion, but more so, and more importantly, effective and efficient insulin secretion.
Okay.
The way they're taken, they're very different. The SGLT2 inhibitors are pills.
Yeah.
They're tablets you take once a day.
Okay.
And the GLP-1 agonists are injectables, just like insulin.
Yep.
But they can be taken once daily. There's actually a twice daily agent.
Oh, wow.
Or weekly.
Okay.
And
So
we may see monthly. We might see depot drugs,
Wow.
but they're still in testing.
Cool. So let's talk about these cardiovascular outcome studies, starting with the SGLT2 inhibitors. I remember when EMPA-REG, the study about empagliflozin, came out in 2015. I remember my attending saying at the time that actually the trial basically had received a standing ovation at the American Diabetes Association, which sounded very absurd to me, but that was the degree of excitement associated with it. Can you tell us a bit about why this was the reaction and the importance of these trial results?
Sure. And you said it really well in the beginning, Angela. Before this trial, we really thought of diabetes as and the effectiveness of drugs in terms of the surrogate marker, which is the A1C and glucose control, when the cardiologists always were looking at us saying, guys, it's really about protecting the patient from cardiovascular disease, and that's because that's why they are dying.
Yeah.
So we kind of had that relationship for a long time, and I would say despite the fact that endocrinologists understood that, we felt like we didn't have the right tools in our toolbox to prevent that devastating stroke or heart attack. So here we are with the empagliflozin study result, the EMPA-REG, where it was a randomized trial. It was about 7,000 patients, and they looked out, which is important, about 4 years. And the goal of the study was to show safety of the drug, or beyond safety. The safety was proven, but it was more about in a cardiovascular population, is it safe? So it was almost, the goal was to show that it was non-inferior from a safety perspective. So lo and behold, within 3 or 6 months, we see a separation of the group, right, in terms of cardiovascular outcomes. And it was statistically significant where we saw a 14% reduction in risk in the overall outcome, which is that combined major adverse cardiac event outcome. But when they drilled it down and looked at heart failure, there was a significant, it was about 40% reduction in risk of being hospitalized for heart failure.
And the main point, the real important thing, was that they actually looked at a group of people, you said, with pre-existing cardiovascular disease, which is something that is very commonplace in patients with diabetes. Yeah,
and that's important because when we look at the other studies, we have to think about the different results, and they depend in part on the population studied. Keep in mind that it takes billions maybe of dollars. Sometimes we've seen, but millions of dollars to run these trials. And that they need to be efficient as possible to answer the question, and that we do that in trial design by choosing a population that is likely to have events in the time frame, in the shortest time frame as possible. So that was one of the reasons they chose that group, but the other was because the FDA mandated that.
And then since publication of EMPA-REG in 2015, there have been 2 additional SGLT2 inhibitor trials that have been published. So CANVAS and CANVAS-R regarding canagliflozin, which came out in 2017, and now DECLARE-TIMI, which was reported on dapagliflozin and published in the journal in print just this January in 2019. Can you summarize the findings of these trials for us as well, please?
Sure. So the CANVAS study was designed pretty similarly to the EMPA-REG study. It had more patients, but there were somewhat fewer percent. There were fewer patients with pre-existing heart disease, and that's probably important when we look at the outcome. The outcome of the CANVAS study was positive. We showed. They were able to show overall the major adverse cardiac events rate was lower, not as a little bit lackluster compared to EMPA-REG, so it wasn't as dramatic, and also they were unable to show a difference in cardiovascular death.
Okay, I see.
And so CANVAS was a little bit less of an excitement. I guess I think it still got an ovation. Now, what we saw with CANVAS that was interesting, though, was a very consistent finding that hospitalization due to heart failure was reduced. We also, and we can discuss further, saw, again, this improvement in the worsening of nephropathy. So patients had a slower progression to kidney disease. So we were happy to see that.
Yeah.
Now, there were some other findings on adverse events we can talk about a little bit later, because that becomes the highlight now of the Canvas study.
Okay.
But let me go on to the DECLARE for a moment.
Yeah.
The DECLARE study with dapagliflozin, I think, took the daring step of including a population that had a far fewer number of patients with cardiovascular disease.
Okay, how interesting compared to Canvas and to EMPA-REG.
Right,
so,
exactly.
Yeah, okay.
And they did this so that they could potentially identify really a disease modifier for patients with preclinical heart disease.
Yeah.
It was an important thing to do, but unfortunately, even though they randomized 17,000 individuals, they didn't see they didn't meet their primary outcome.
Okay.
What they did find, again, we're happy to see a reduction in hospitalization with heart failure. And it makes sense to talk about that for a second, because these patients were none of them in the DECLARE, the Canvas, the EMPA-REG, they weren't selected for having heart failure at baseline. In fact, baseline heart failure was low.
Okay.
But we're seeing this reduction in hospitalization for heart failure.
Yeah.
So clearly there's some subclinical heart disease that we as clinicians need to be aware of.
Yeah.
And hopefully we'll get some guidelines around that.
And that's actually, I think, quite an important point to make to our listeners, because a lot of the initial positive reaction to all of these trials is surrounding the outcome of there being a reduction in heart failure hospitalizations, when in reality that wasn't a primary outcome, that was a specific target. I guess it raises as many questions as it does answers in that sort of situation. Yeah.
Yeah. I mean, it was disappointing, I think, to the trialists or to the company perhaps that it was a secondary outcome that they found. But what was so critical for our academic community and for our patients was that it was a consistent finding. So we really now know what to do. With these medicines, I think.
So I guess with that, I wondered, do we really think that is a true signal? And moving forward, would that be something that you would foresee is going to go into guidelines in terms of treatment of these sorts of patients?
For sure. And we already see even the American Diabetes Association has revamped their entire clinical algorithm for treatment of diabetes using medications to advise clinicians to decide, look at the patient in front of you. Does this patient have heart disease, yes or no? And what type of heart disease, in fact?
Absolutely,
which we can get into more when we talk about the GLP-1 receptor agonists.
Absolutely. With these SGLT2 inhibitors, you had mentioned that there was a slowing in their progression of their renal disease. I think the only other medication class prior to this that had shown some of this was the ACE inhibitors, the ARBs. So, and renal disease burden is a huge complication in diabetes. So can you tell us a little bit about those findings in these studies?
Yes, great. And I would add to your point about the ACE inhibitors that I think you could argue we had evidence also that insulin and sulfonylureas did reduce the worsening of nephropathy. We saw that in the UKPDS for type 2 and insulin and sulfonylureas, and then DCCT. But I think what your point is that this was an unexpected result in a trial that was not seeking to control glucose. And so the impact, I think, of that is pretty great. This is a condition that many patients fear. We do know that the rates of end-stage renal disease have reduced dramatically around the world. Of course, there are spots around the world where glycemic control remains extremely poor and progression to end stage is still a serious problem. But remember that worsening nephropathy is not just about eventually developing dialysis or needing dialysis. It's also about medication adjustments as you get older, not being able to take certain drugs, having adjustment. I mean, and then certainly as people progress, they don't feel as well. There's a quality of life issue. So it's a critical finding. I think it makes us all feel certainly a lot more positive about this drug class, keeping in mind that it's been around for several years, and it's not since this trial. It's really since this trial that we started to use them.
So now that it has been kind of 4 years since that original study came out, do we have a clearer idea as to why these drugs confer these cardiovascular and renal benefits, or is that still something that remains to be elucidated?
That's a great question. I'm going to say the answer is your latter. I think that we still need to elucidate mechanisms. I think that the best theory thus far is a combination of the drug being, the SGLT2 inhibitor being a diuretic for patients who are prone to developing volume overload, in addition to potentially improving the utilization of certain fuels. What we've learned is that the SGLT2 inhibitor does promote a mild starvation state. And as you remember from medical school, that this produces an elevation in ketone levels. We call this ketosis. And also glucagon levels. Now, how those two are playing a role, we don't know necessarily, but we do know the heart really has an easy time utilizing the ketone body. And
as a fuel source.
And so it still prefers fat, but if you have more of a shift away from glucose and toward ketones, there may be a functional benefit. And then as far as the nephropathy goes, there's this concept that my nephrology friends are trying to teach me, which is really hard, which is tubuloglomerular feedback. Which is like, it's sort of like an endocrine axis. And we do know that when glucose is dumped into the distal part of the tubule, there's some feedback that might promote glomerular function.
Oh, that's really interesting.
It is, yeah. We need to learn more, don't we?
Well, we always need to learn more. That's really interesting. And you also mentioned that specifically, which I guess is an important time to just remind our listeners, the SGLT2s do utilize a different fuel, and some of that includes increased ketone production, and that can obviously be problematic in and of itself.
Good. I'm glad you brought that up. So ketoacidosis is a rare but serious complication or side effect of the SGLT2 inhibitors. It's in essence, it's an excess. It's that normal process that we're seeing with the ketosis driven to excess. So as you might imagine, we see this more commonly in patients who are insulin deficient. Because not to go too heavy here, but insulin suppresses ketosis. It's sort of the I'm fed signal. And type 1 diabetes patients have been exposed to SGLT2 inhibitors. It's not FDA approved for that condition, but it is effective if you look at the trials that have been done. But it's probably, for most patients, not worth the risk of ketoacidosis. In type 2s, we see that occur, but typically in patients who've been exposed to prolonged fasting. Most of the time. So preparing for surgery or taking the medicine in the setting of surgery, which I haven't seen, but it's been reported.
And then are there any other triggers or things that we should be thinking of?
That's a great question. I think probably severe illness. What I advise my patients to do is to actually stop the medication in the setting of an illness that is likely to be prolonged or leads you to become dehydrated. One of the necessary items in the recipe for DKA or diabetic ketoacidosis is dehydration.
Of course.
So I say it right out to my patients. If you are dehydrated, you should skip it.
No, that makes perfect sense. So we've covered quite a lot about the SGLT2s. Let's just move very quickly over to the GLP-1s. Several cardiovascular outcome trials have also been performed in this drug class, but only liraglutide has shown any cardiovascular benefit with the LEADER trial, which was also published in the journal. This was back in 2017. Can you tell us a little bit more about LEADER's outcomes, and I guess why liraglutide had that cardiovascular outcome benefit, but perhaps some of the other drugs in that class haven't hit that target?
Right. Well, actually, we have seen some results come out from other drugs, but they're not as strong. And in fact, one of the drugs, semaglutide, is really the benefit is in stroke.
Oh, okay.
Versus classical cardiovascular disease, including MI. But the liraglutide study was certainly it set the stage for the future of this drug class.
Yeah.
By with its trial, which enrolled about 9,000 patients. So you're going to see that's about the range these studies are.
Yeah.
And it found a reduction, around 12% reduction in the risk of developing either cardiovascular death, MI, or stroke, and that was heavy. Leaning in the cardiovascular death part of the MACE.
That's very interesting, isn't it?
Right.
Yeah.
So really, it's that's why it's been viewed similarly to the EMPA-REG study.
Yeah, absolutely.
Because we actually saw patients dying less.
Yeah.
So dramatic, not something that we've seen with any of our other diabetes-focused agents. And we also happily saw all-cause mortality come down, just like an EMPA-REG, and the worsening nephropathy signal came. We saw that as well.
Yeah.
Now, you mentioned the other agents. So we have seen semaglutide, we have seen a stroke reduction, surprisingly, just stroke. But not so much. The albiglutide, which is the Harmony study, was similar to LEADER, and we did see a reduction in MI, but not death or stroke. Yeah. And we didn't see actually any secondary outcomes, major secondary outcomes with that trial. But you're right. I think liraglutide is now still remains. I think the drug that folks are paying the most attention to as far as asking the question why it had such an impact.
And do we have any idea as to why it had the impact? Or is that also something that is in the to be determined space?
Exactly. I think there's two answers to that. One is that the liraglutide trial in participants were very high risk, similar to what we saw with EMPA-REG. Yeah. So it was the right population to identify a benefit. It's also an analog to GLP-1 agonists versus the exenatide, for which we saw no benefit across the board, is actually derived directly from exendin. An exendin molecule, which is a molecule that we identified in the Gila monster spit. So you might remember that. And it actually is different. Okay. And so the question is whether we really need to refine the molecule and the cross-reactivity with other GLP receptors might be relevant. Yeah. So I think what we all kind of are thinking is that the GLP-1 receptor agonists, at least the analogs like liraglutide, are beneficial to those with atherosclerotic heart disease, but it will take time to demonstrate that. It's not as an acute effect as we saw with empagliflozin in heart failure. And the reason why we might see that I think people are furiously studying that. There definitely are receptors in the heart and on the endothelium. Yeah. And I think that's to be determined. We definitely know it has an impact on blood pressure, weight loss, and heart rate actually comes up with these drugs. So
that's quite interesting.
It's surprising to hear that it's
surprising.
So good for the heart. Yeah. But it looks like we're going to open a new chapter in the textbook.
I think a point of differentiation, just to make, as you have alluded to, is that we're looking at different mechanisms of heart disease almost now, because we're looking at heart failure group versus atherosclerotic disease group, and we've got two different classes of medications where perhaps the benefits will be seen in different cardiovascular diseases, so to speak.
Exactly. You got it.
That again. So if we make it a bit more clinically orientated and use a case, we've got Brian, who's a 68-year-old man. He's had type 2 diabetes for 10 years. He initially had good glycemic control, but in the last 3 years, it's just become more difficult for him. His HbA1c is now always above 9%, and he doesn't check his blood glucose levels. And he tells you, as some of our patients do, do that they don't need to check. He can feel what his blood glucose levels are. So his kidney function is okay. His EGFR is greater than 60, and he is overweight with a BMI of 29 kilos per metre squared, and he hasn't yet had any cardiovascular events at all. He's currently being treated on metformin, 2 grams daily, as well as a statin and an ACE inhibitor. So the guidelines suggest that metformin should universally be the first-line agent of choice. But with this type of patient, this type of type 2 diabetes, how would you approach treatment now?
That's great. So Brian's a pretty typical patient that we see. A couple of things that we need to understand about him. He does meet the criteria for being an older adult, whether he likes it or not. So we do consider those over 65 a group where we really have to understand their functional status and their cognitive function and their longevity. It turns out cognitive function and functional status predicts longevity really well. So I want to hear a little bit more about, is he working? Is he out in the garden? Is he truly doing very well? He probably is, because I can see he hasn't had a vascular event, and assuming that he's generally healthy, let's proceed with moving him toward a reasonable glucose target, certainly below 8. But in his case, he might do well under 7 if we can get there without hypoglycemia.
Yeah, of course.
So to do that, given he's up there in the 9s, I'd like to talk to him about his personal goals. If his and talk to him about his targets. If he's engaged and he's interested, I think the best next step for him would probably be a GLP-1 receptor agonist. And I say that mainly because of potency. And he is overweight. He's borderline obese. The GLP-1 receptor agonist will achieve an A1C lowering around up to a 1.5%, depending on the trial you look at, versus the other cardioprotective drug, which is the SGLT2 inhibitor, isn't as potent. It's also a choice for him. In fact, if he says, I really can't inject, doc, I'm not ready for that, we might move along to an SGLT2 inhibitor.
And that's a really important point to make in terms of diabetes treatment these days, because there's so many choices out there, really, and the ADA guidelines, all of them are starting to come out. It really comes down to that very patient-centered kind of more mindful approach, rather than, it's definitely no longer a one-size-fits-all approach in land of diabetes.
That's right.
Is it?
That's right.
So in this elderly gentleman who is a bit overweight and otherwise has good renal function, hasn't had a cardiovascular event yet, your suggestion would be a GLP-1, simply to get the weight down, to give him the maximum glycemic improvement for just one medication. But if Brian had a history of a recent myocardial infarction, would your approach then be different, or would you go along the same path, given that both these medications seem to have some effect?
Right. And I think that's right. I might go down the same path, but I might have a little bit more data in my, in my calculation. So if, for example, his post-MI echocardiogram was demonstrated some cardiomyopathy that may or may not be reversible, I would feel compelled to actually use an SGLT2 inhibitor. In fact, we do take that approach with our patients in our hospital who have recently had an MI, especially if they have evidence of cardiomyopathy on their post-MI echo. So that would go into my calculation. The other would be looking a little bit more at the existence of nephropathy. I would say that the SGLT2 inhibitors are so consistently beneficial there.
Of course.
I might push him in that direction post-MI if he has microalbuminuria.
No, that makes absolute sense. So then, because a lot of our listeners are residents and medical students who only tend to encounter these agents in the inpatient setting, if Brian had an MI, is then admitted to hospital 12 months later with acute cholecystitis and a plan for cholecystectomy, what would be your advice, Marie, on how medication should be managed in this specific sort of setting?
Okay, great. I'm first just going to quickly address the fact that Gallbladder disease is known to be increased in those on GLP-1 receptor agonists, and I think probably his cholecystitis was related in part. It could have been related to the fact that he was on a GLP-1.
Darn it.
Darn.
Yeah.
So sometimes I actually make sure I discuss that with patients, even though that's a low incidence side effect.
Yeah.
But it's an important question. What we would say in the hospital is that we don't have enough information on the use of non-insulin agents, and insulin still is the mainstay.
Yeah.
However, there's good data on the DPP-4 inhibitor drug class, which we didn't discuss, but isn't super potent. Probably wouldn't be useful in Brian because his diabetes coming in the door is relatively poorly controlled.
Yeah.
Assuming it should have been better by now. But I suspect insulin will be the mainstay. I would also say that given his prolonged, relative to normal life, he has a prolonged starvation state post-op.
Of course.
And this is normal. And he probably came in with poor nutrition, given that he may have had pain for several days.
Yeah.
SGLT2 inhibitors really should be on hold.
Yeah.
If that's the path we went.
Yeah.
Until he's eating very well.
Yeah.
Now, going back to the GLP-1, now that he's had his gallbladder removed, I'm actually enthusiastic to start it again when he's ready.
Yeah.
But not in the hospital.
Yeah. So you would wait until eating and drinking and well again outside of hospital.
That's right.
And is that your usual rule of thumb for a lot of the diabetes medications, that you would just wait until people are healthy and eating and well enough before restarting there?
Exactly. That's our rule of thumb. We might be a little too ginger about that in some cases. I think DPP-4 inhibitors can just be continued. They're quite clearly safe.
Yeah.
Metformin probably doesn't have to be held for the entire time.
Okay.
But certainly until we understand what's happening with the kidney.
Okay. Of course. Yeah. Okay. Thank you a lot. So you've mentioned a few of the reasons why you would or you wouldn't start Brian on a certain type of medications. But I guess outright then, what sort of patients would you absolutely not start any of these new medications on that we're all so excited about?
Right, exactly. And that's when it comes down to, what's happening in the clinic when you talk to patients. So I mentioned earlier that the Canvas trial revealed to us that the SGLT2 inhibitors could be problematic in some patients. Number one, and we saw amputations, a higher risk of the distal toe amputations. We didn't see that in the other trials, but because of that finding, which was really borne out in our RCT that was beautifully done, we do withhold that medicine in patients who have active distal vascular disease. So, and I don't withhold it in people with neuropathy, rather, because that's so prevalent, but rather those who we think could be at risk. The other thing we saw is increased fractures in canagliflozin. So people with osteoporosis, men and women, I would probably not prescribe an SGLT2 inhibitor at this time.
Sure.
And that brings me to my female patient, who is at really a high risk of a candidal yeast infection, a vaginal yeast infection, which we think of as a nuisance, or men tend to think of it as a nuisance. Women have a little different feeling about it sometimes, where they may have had multiple episodes and they really don't want a drug to do that to them. So we have to counsel them about risk benefit there. Frequent urinary infections is another another condition where we would probably consider a GLP-1 over the SGLT2, because we saw that increased rate in the trials. Okay. Now, the GLP-1 receptor agonists are interesting because we know a lot about their side effects and understand, how to predict them. In the semaglutide study, SUSTAIN, we saw about 40% of patients had the nausea that we know is so prevalent.
Of course,
right? So we have to counsel patients, and those who have a history of pancreatitis, we do not prescribe, because there have been signals, although it hasn't borne out very clearly. And those who have GI conditions that are already associated with significant nausea, we would steer away.
Okay. Yeah. One last question. Given that we've spoken about a lot of these new drugs, new trials, new models of trials, what do you think is the future direction of these sorts of medications? It almost sounds like endocrinologists are becoming cardiologists.
Or maybe the other way around.
Yeah. So where do you think kind of this area is headed, and what, like, their uptake is already high, costs are also high, but it sounds like this is a new standard of care. Is this the right direction that we're all moving in?
That's really the big money question, I would say. I will note that we have to consider treatment burden in the individual patient. Can they afford this drug? Is the side effect profile acceptable? And if we get through that, and we often do with these drugs, it's the race is to try to access them for the patient because of the cost. So what I'm hoping to see is that that we reshape the way we treat diabetes early on to be target focused, meaning achieving a good A1C early, and also using medicines that do not promote weight gain. So patients have a much better position early, and as the disease progresses, prioritize the drugs that we know actually modify the cardiovascular event rate. But really, I think that the guidelines say that exactly that now. And we, as far as heeding them, we're going to need partnership from not only clinical societies, but certainly the payers, insurance companies, and pharmaceutical companies. Because if we need to open up the ability to develop generic versions of the drugs, which can be blocked by certain mechanisms. But I know in general, industry wants to support what they do and the patients. I just think that we have to kind of push them to do that.
No, that's a very fair point. So thanks so much, Marie, and for joining us in conversation as we take deeper dives into papers at the NEJM. I hope we've given our listeners a bit more insight into both aspects of clinical practice and a point of access to the primary literature that makes up New England Journal of Medicine. And so, by taking a deep dive into the literature around the management of type 2 diabetes and these new classes of medications associated with cardiovascular and renal benefits, what have we learnt and how has this shaped practice? Well, firstly, there are two new classes of medications available for the treatment of type 2 diabetes, the SGLT2 inhibitors and the GLP-1 agonists. Trials performed in these two drug classes were carried out in patients with established cardiovascular disease, which has shown benefits in terms of heart failure hospitalizations, a reduction in the progression of renal disease, and potentially improvement in subclinical heart disease or subclinical heart failure for the SGLT2 class. In the GLP-1 class, we've seen a reduction in cardiovascular mortality, reductions in stroke, and a reduction in perceived atherosclerotic cardiovascular disease burden. The mechanism of how these drug classes confer their cardiovascular benefits are yet to be elucidated. Currently, it is hypothesized that switching to ketones and to fats as fuel with the SGLT2 inhibitors confers cardiac cell benefits. In the GLP-1 receptors, which are found in many tissues all throughout the body, there is some speculation that direct GLP-1 effects on endothelial cells and vasculature has some benefits. However, we need to bear in mind that these mechanisms are all currently hypotheses and need further investigation to be fully understood. And finally, in terms of choosing treatments for patients with type 2 diabetes, the important takeaway is that the approach is now very much patient-centered. Patients with clinical or echocardiogram evidence of cardiac failure or renal dysfunction should be considered for SGLT2 inhibitor use, bearing in mind the risks of ketoacidosis, urogenital yeast and fungal infections, as well as osteoporosis risk, which was seen with canagliflozin. Patients with atherosclerotic disease who might have an increased BMI would certainly benefit from GLP-1 agonist use. And both SGLT2 inhibitors and GLP-1 agonists should be ceased when a patient is admitted to hospital, particularly if they are fasted or in a catabolic state. And then you should consider restarting these medications when your patient is eating and drinking normally again and out of hospital.
So once again, thank you for listening to this episode. Please visit our guide on diabetes at resident360.nejm.org. I want to thank our expert today, Dr. Marie McDonnell, our production team here at NEJM Resident 360, which includes Karen Buckley, Carl Simmons, Mike Tomasis, Tim Vining, Scott Williams, and Kathy Stern. Also a special thanks to Dr. Angela Castellanos and Dr. Amanda Fernandez, my co-editorial fellows at NEJM this year, and our NEJM education editor, O.P. Hammond-Vick. Because this is a new series and we're trying something new, we want your feedback, so please email us at resident360@nejm.org. Leave a message or review wherever you get your podcasts, or feel free to reach out to us via the NEJM Resident 360 website. We're also accessible via various social media sites, including Twitter, Instagram, and Facebook via the nejm.org pages. I'm Dr. Angela Chen, editorial fellow at the New England Journal of Medicine. Please join us again for our next episode.